The heart is a very beautiful organ, and here I have drawn a cross-section of the heart where you can see the various different compartments. You've got the right atrium, the right ventricle, and the left atrium, and the left ventricle, and the right side of the heart, of course, pumps blood to the lungs, which would be on either side of the heart, and this blood returns back to the left side of the heart through the left atrium, and then blood is pumped again from the left ventricle out into the system, all the way down to the legs, and then up to the brain as well as the arms, through the aorta. And of course, this entire process is essential for life, for delivering oxygen to the tissues, delivering nutrients, all of that. And so you would imagine failure of the heart pump results in less output, less cardiac output, which means less tissue perfusion. A patient would no longer be able to distribute all that oxygen. But what could cause failure? Well, failure of the heart can result from valvular problems. So, for example, if the aortic outflow tract, which is right here, is perhaps damaged or narrowed in some way, it's going to make it extremely hard for blood to be pushed out through the aorta and out to the system. So valvular problems can be a cause of failure that leads to shock. Arrhythmias, which means there's an issue with the electric conduction through the heart, which allows it to function and pump our entire lives. There could potentially be stiffness of the ventricular wall or the wall of the heart, which prevents it from being able to contract properly. And if the pump itself is so severely disabled, this can lead to shock, lowering of the blood pressure, and decreased ability to deliver the necessary oxygen to the tissues. And I want to highlight that heart attacks are the major cause of cardiogenic shock. So MIs, myocardial infarctions, cause decreased contractility. So what you'll see is, for example, if we look at the left ventricle, if blood can't be pumped forward, it'll back up, and it'll back up into the left atrium. And when the heart can no longer accommodate all this fluid overload, it's going to back up into the lungs as well, each side of the lungs. And as things get worse and worse, it'll back up into the veins and all the way into the right side of the heart, and it can be backed up all the way into the system as well. So this is really known as fluid overload. And there are just a couple symptoms that I'm going to point out. So for example, pulmonary congestion. Pulmonary congestion. Like I said, blood is backing up into the lungs, and so that may make it difficult for patients to breathe, and they may have a cough that's productive with a lot of fluid, and that's really the blood backing up into the lungs. You may see something called increased jugular venous distension. That's JVD. And jugular venous distension is basically the jugular vein gets distended, because as you see here, this blood backs up into the venous system, and it can back up all the way into the neck. And of course you might see chest pain, also known as angina, as the heart is starved for oxygen. And then of course you may see the different symptoms that you would see in other shocks, such as organ failure, organ dysfunction, decreased urine output, and all of this is caused by decreased oxygenation of those different organs and tissues. You will likely also see cool skin as blood is being diverted away from the skin and to more vital organs such as the brain or the heart and the lungs. So with these symptoms and these causes of heart failure, how can we diagnose cardiogenic shock in a patient? Well, let's take a look over here so we can take a look at the diagnosis of cardiogenic shock. And so diagnosis will include, of course, your typical labs such as serum lactate or ABG, assessing the oxygenation and the failure of tissues to utilize oxygenation for their biochemical needs. But also, you're going to want to look at different things that might be causing heart failure. So, for example, you might want to look at troponins, which will show if there's any tissue damage or damage to the heart, like in the case of a severe heart attack. Or maybe you can look at a chest x-ray. So here is a normal chest x-ray with the clear lung fields. You can see this diaphragmatic recess, so there's no fluid accumulation here. And here is a congested heart and lungs. You can see this kind of fluffy fluid accumulation where the pulmonary veins are. So over here on our little heart picture, the pulmonary veins are really congested because of the backup of fluid from the left side of the heart. And you can also see this sort of blunting of the diaphragmatic recess. It's no longer, here it's still a little bit sharp, but on this side you can see it's starting to get blunted a little bit. So you can kind of make out the outline of the diaphragm and where it meets the chest wall, but it's somewhat obscured as compared to the normal view. And let me actually go and erase that so you can see it again. You can see how it's still kind of obscured versus over here. Or maybe you might want to look at an EKG for different signs of arrhythmias or a heart attack or something like that. Or take it one step further and get an ultrasound, an echocardiogram, to take a view of the heart. This heart ultrasound will allow you to see the contractility of the heart, how well it's squeezing blood. And so I highlight all of this really just to say that you want to look and see what's going on with the heart. What is the problem that's causing this cardiogenic shock or heart failure, so that you can potentially correct it. But aside from these lab values, two ones that are particularly important in cardiogenic shock are evaluating the PCWP, which is pulmonary capillary wedge pressure, and the cardiac output. So here we are. Let's zoom back down and take it over here and look down here so we have a little bit more room to play around with. And again, I'm going to erase a little bit. So first, let's go ahead and tackle the pulmonary capillary wedge pressure. Now, the pulmonary capillary wedge pressure is determined by inserting a catheter to go through the venous system into the right side of the heart and up into the pulmonary arteries to essentially the capillaries. And that's why it's called a pulmonary capillary wedge pressure. You wedge this pulmonary catheter all the way into the pulmonary capillaries. And the reason you do this is to assess back pressure from the heart. Remember, in cardiogenic shock, fluid from the left ventricle builds up and backs up into the lungs and into the pulmonary arteries. And so this backup of fluid actually creates a pressure. Whereas the pressure is normally less than 15 millimeters of mercury in the pulmonary arteries, near the pulmonary capillaries, the pressure in cardiogenic shock will be above 18 millimeters of mercury. So this will be a way you can diagnose cardiogenic shock when you're trying to figure out what type of shock this may be. And the second thing that you can take a look at with the heart is cardiac output. Now, I had mentioned cardiac output or cardiac index. And cardiac index might be a word that you haven't heard before, don't really understand what it is. Well, cardiac index is essentially the cardiac output over a patient's body surface area. And cardiac index is really used to standardize cardiac output. The idea here is that patients come in many different shapes and sizes. They can be very tall, like NBA players such as Michael Jordan and Kobe Bryant, or normal-sized, a little bit smaller than a basketball star, or even shorter, like children, for example. So with different heights and weights of patients, cardiac output varies. And that's why you can use body surface area to really create a standard value that can be used in place of cardiac output. And cardiac index in patients with cardiogenic shock will be less than 2.2 liters per minute, so that's cardiac output, over meters squared, and that comes from body surface area. Oh, and the normal of cardiac index should usually be between 2.6 and 4.2. Now, so how do you calculate cardiac output? Well, there are actually a number of different ways. And I'm going to break it down into ways that are considered more invasive versus ways to calculate cardiac output that are less invasive to non-invasive. And as we progress into the future, you'll see that we are progressing as a society towards more non-invasive procedures, just because it's safer for patients and requires less downtime for healing and causes less issues for patients. But first, let's look at an invasive measure of cardiac output. You can use a pulmonary artery catheter, just like you use to assess the pulmonary capillary wedge pressure. So if you already need to assess this pulmonary capillary wedge pressure, then you can kill two birds with one stone and measure the cardiac output along with it. So this is the pulmonary artery catheter. Next, you can use another catheter that's a little less invasive, known as an arterial line. An arterial line is a catheter that targets the artery in a patient's arm. And this catheter can assess the cardiac output by looking at the pressure waveform of the blood pressure. So by assessing the blood pressure, cardiac output can be calculated in a patient with shock. Another way to assess cardiac output is through a CO2 absorber. Now, a CO2 absorber actually requires that a patient be intubated or to wear a rebreather mask. Essentially what it does is it measures the amount of carbon dioxide that is being exhaled, and at the same time delivers 100% O2. By only delivering oxygen and measuring how much carbon dioxide the patient is producing, it can calculate cardiac output. Here's a visual so you can understand this a little bit better. So here's a blood vessel, and here are cells that I'm drawing in orange. And let's say the blood is progressing in this direction. As cells work to create energy and utilize oxygen, they also produce carbon dioxide. And of course, that's where carbon dioxide is coming from cellular production. So it would stand to reason that CO2 concentration in the arteries changes as you progress through the capillaries and into the venous system. So by assessing the carbon dioxide produced and the carbon dioxide in the arteries and the veins, you can actually determine how fast this blood is flowing through. And by knowing this blood flow, you can actually determine cardiac output. So through this method, you can also calculate cardiac output. And finally, probably the least invasive way to calculate cardiac output is through an echocardiogram, also known as a heart ultrasound. As we had shown before, an echocardiogram can actually take a look structurally at the heart, but also see how much blood is filling the heart and how much blood can be squeezed out of the heart with each beat. By directly observing this, cardiac output can be calculated. So remember, cardiogenic shock is a faulty pump, and by assessing that pump's function, we can better learn how to approach a patient with cardiogenic shock.